My name is Abdou Elhendy. I'm a clinical associate professor of medicine at the University of Wisconsin, Madison, Wisconsin, and a practicing cardiologist at Marshfield Clinic, Marshfield, Wisconsin. I have made a presentation in the 22nd Congress on Heart Disease on non-invasive evaluation of coronary artery disease in obese patients. Obesity represents a serious health problem that affects up to 35% of the population. It is estimated that 5% of adults are morbidly obese. Various studies have shown that moderate to severe obesity is associated with increased morbidity and mortality, increased cardiovascular events, and increased cost of health care. Coronary artery disease risk factors increases across weight classes. Therefore, identification of a method for evaluation of coronary artery disease will help in identifying patients who are at high risk. Therefore, identification of patients with coronary artery disease. I'll go again.
Okay. 1 second.
Okay.
Okay.
Therefore, the identification of a non-invasive method for evaluation of coronary artery disease in these patients is important in order to intensify medical therapy and identify patients who might benefit from revascularization. Evaluation of coronary artery disease in obese patients may be difficult. Clinical examination may be limited by body habitus, difficulties in auscultating heart sounds. Patients may have dyspnea and absence of congestive heart failure. There is high incidence of diminished exercise tolerance and sleep apnea. Furthermore, many patients have baseline electrocardiographic abnormalities due to hypertension or left ventricular hypertrophy, which may preclude the assessment of ischemic changes in the electrocardiogram. Many imaging modalities have limitation on the weight on the imaging table, which makes it impractical to perform the test in morbidly obese patients. The first test we discussed is stress echocardiography. It is a widely used technique. I go again. The first test we discussed was stress echocardiography, which is a widely used technique for evaluation of coronary artery disease. The limitation with this test in obese patients include poor imaging quality, which can be occasionally encountered due to body habitus, and increased chest wall thickness. The administration of myocardial contrast agents can help improvement of endocardial border delineation and rendering the test diagnostic. Furthermore, myocardial perfusion can be evaluated with echocardiography with contrast, and this enhances the sensitivity to detect coronary artery disease in obese patients. Many studies have shown the good diagnostic value and prognostic value of stress echocardiography in obese selected patients. The test has also been applied prior to bariatric surgery to evaluate patients for ischemia. Nevertheless, the incidence of myocardial ischemia in this particular population is low. And therefore, I'll go back. Nevertheless, the incidence of myocardial ischemia in this particular population is low. The second test we discussed is radionuclide myocardial perfusion imaging, which is widely used and has good diagnostic and prognostic value in a wider population. Particular limitations exist in obese patients, particularly imaging artifacts due to diaphragmatic breast attenuation and other forms of artifacts due to increased body weight. There are many techniques that can be used to overcome this. One of them is using attenuation correction. Using hybrid CT allows adding functional and anatomical information and evaluation of coronary artery calcifications as well. The next technique that we discussed was magnetic resonance imaging, which can be applied with stress testing, either with dobutamine or with vasodilator stress. You can assess myocardial perfusion and function. Many studies have shown that the diagnostic accuracy of this technique is higher than echocardiography and myocardial perfusion imaging using radionuclide agents. The observation of myocardial ischemia or late gadolinium enhancement is associated also with outcome in these patients. The second test that we discussed is coronary calcium scoring. It's a simple test that you can use it with a low-dose CT scanning. Coronary artery calcifications increase across weight classes and is predictive of outcome. The presence of coronary artery calcification can precede the presence of myocardial ischemia, and therefore early identification of atherosclerosis may help identifying patients who require more aggressive risk management. Finally, we discussed coronary CT angiography. Despite the limitation for artifacts and body weight, coronary CT angiography is increasingly used, and with modern technology, it is possible to achieve very diagnostic images in obese patients, and many studies have shown that this can predict prognosis and can help selecting patients who would require invasive coronary angiography. In summary, obese patients are at increased risk of cardiovascular events, particularly the morbidly obese patients. I'll repeat that. In summary, morbid obesity is associated with increased morbidity and mortality and increased cost of health care. Coronary artery disease is a major problem in this population, and cardiovascular mortality is associated with morbid obesity. Identification of the ideal non-invasive test to diagnose coronary artery disease in these patients is essential. Careful consideration of the merits of each technique is important in order to improve allocation of health resources and improve outcome of these patients.